Let me see. You hear me now, right? Okay. Good morning. Good morning. Okay. So it's my pleasure to be here today. My name is Amir Kazory. I am a professor at the University of Florida. This is the third time I am here with you guys, and not with you guys necessarily, but with the American Canadian School of Medicine. It's my pleasure to be here. This week, we are going to have a number of lectures together. It would be 2 hour lectures in the morning, and then I guess for the third days at the end, I will be also in the small group sessions. So normally I ask you your name and all those, but this time, thankfully, there's a lot of you. So I pass on that, and hopefully we'll get to know each other over the next few days. The first session of the first day is, as you see, renal potassium handling. What does that mean, really? Why did I put strawberries here? Do you know? I I don't know if I hear it this bad or you hear it the same bad as I do. It gets interrupted. Hopefully, it will be better. So why did I put the strawberries? Those who have been here last year, they know about it. Why do I do it? Just because they are beautiful and red and all those? That's one reason I have to admit. But there is another reason for it. Because the strawberries have a lot of potassium in them, right? Yes, yes, yes. All the fresh fruits have a lot of potassium in them. Some of them have a lot, some of them less. Apple has a little bit, banana has a lot. Pineapple has a lot of potassium in it. Kiwi has a lot of potassium. Anyways, so you know what? For the next week or so, this is what you are going to hear from me. My job is not to repeat what you already have access to. You have Kaplan, you have Google, you have ChatGPT. You put renal potassium handling in ChatGPT, it gives you 25 pages. You don't need me for that. My job is to simplify things for you, make it understandable. That would be my job. I hope by the end of this week, you will feel that I have done a good job. Time will tell us. This is the logo of Apple, the usual Apple computers that we use these days. When it came in first, I don't know, a few decades ago. I don't know when exactly it was. My job is to make it with this new apple, just make it simplified. We could go to Newton, an apple falling from the tree. It's too much. Honestly, it's too much. Okay. Why should I know about potassium? When you say, hey, we have a session on potassium, the first question that you have is, why should I know about it? Why do I care? Right? The reason I care is that, look at here, and it doesn't show on this thing. I guess I should use the cursor, I assume. So what it tells you is that, you know, when here it doesn't show. Let's see if it shows with this. Here it shows it. It doesn't show on. Oh, it shows. Okay, very good. To here, do you see it? I hope you see it. It's small. So what? Why is it important to know about potassium? Why should we know about it? Because between 4 and 5 is normal. This is where you and I we are living. That's great. If I go less than 4, it would be bad. If I go more than 5, it will be bad. Depletion or excess will be bad. And why is bad when it is hypokalemia or low serum potassium level? It gives us arrhythmias, it gives us muscle weakness, it gives us it gives us hypertension and death. On the other side, if it goes high, it gives us a number, again, arrhythmias are there, muscle weakness is there, it gives us bradycardia and death. You see, there are lots of things that are actually common. So arrhythmias and muscle weakness go both ways. If somebody, as a nephrologist, if somebody comes and tells me, for the last 2 weeks, I have started to be very weak, I'll be worried. This might be a potassium issue. Yeah, sure enough, it can be anything. But for a nephrologist, my red flags go up. I will be thinking about the potassium issues. So And disorders of potassium affect muscle function and nerve conduction because it changes the membrane voltage of the cells, right? So, if it changes the muscle function, what's the most important muscle you and I we have? Is it the brain, the muscle? There's another better muscle we have than the brain. Yes, the heart, right? Or diaphragm for breathing, right? You know that diaphragm plays a major role in breathing, and the heart is a muscle. So when I tell you, oh, disorders of potassium will affect the muscles, it's not. I'm not talking about my deltoid. I'm talking about big deals. It can kill me because it affects my heart, my most important muscle. So the one factor is professional tennis players need their muscles in their best shape for several hours in a row. Those of you who follow tennis players, you know that 2, 3, 4 hours they are just keeping playing, and it is really at a high level. They need their muscles, right? So the question I have is, what would you recommend as a perfect snack for them on the court? When they are playing this hard, they need to replenish their muscles. What do you think they, when they stop for 10 minutes, 5 minutes, that they have a break? What do you think is a good snack for them when they are using their muscles? I don't hear you very well. I do think you guys also don't hear me very well. I have to tell you, this audio visual, wala la la. Okay. So I don't hear you well. Well, tell me. Okay, you guys know it. Very good. You shouldn't say it. Yes. These are the tennis players. Look at them. All of them have the same snack. They're not crazy. They know what they are doing. They are at any single second of their life is planned by the coaches, right? They have 25 coaches for that one person. All of them are getting bananas. Bananas, first of all, they are not messy in front of 2,000 people. You are not messing it. And then it is filled with potassium. You replenish your potassium in your muscles for the next round. Okay? Very good. They don't take cheese puffs, for example. So, you remember periodic table of the elements. I assume you do remember it a little bit. When you look at everything here, I have something here. This is the potassium. Do you remember potassium? Do you see? You probably don't see it from here. It says 39, the atomic weight. Do you remember the atomic weight from the time you were in high school? Or this is what you are going to tattoo in your brain. There's nothing to learn about this. You need to memorize this. 1 millimole of potassium equals 1 mech milliequivalent of potassium equals 39 milligrams. You need to remember it. Next time you go to grocery store, you are looking at the label, you are not seeing millimole or mech. You will see milligram. You need to know how to convert this. So one, and we are going to use this quite a bit today and other days. 1 millimole of potassium is 39 milligrams. Keep that in mind. Okay, where is potassium? You tell me that potassium is important. You told me that we need the potassium everywhere, but you didn't tell me where the potassium is in my body. Now it's my body. Tell me where my potassium is. Here it is. So 2%, only 2%, the tip of the iceberg is here. Only 2% is this extracellular fluid. The majority, the great majority of potassium is inside the cells, right? Intracellular fluid. So if I have 4,000 millimole or mech of potassium, only 80 mech is out. More than 3,900 is inside the cell. So 2% out, 98% inside the cells. So it is an intracellular ion or ion. Only 2% is in the extracellular fluid. Remember, you and I have access to vein, which is the blood, which is inside the cell or outside the cell, outside of the cell. So you and I, we have access only to that 2% when we are measuring stuff. When I tell you my potassium is this, I am talking about my potassium outside of the cells, right? I didn't go through the cells to see how much potassium I have. Do you remember this? Perfect. Okay. So this is a cell. Just keep in mind, and it just blows your mind when you look at this, when you understand this. What it tells you is that, hey, the usual potassium in your serum, in your extracellular fluid, we said it is 4 millimole or merc in every liter. That's the usual concentration. That's the normal concentration you and I have. If you and I we go to the lab today, it would be 4.2, 4.3, 3.9, 4.8. This would be for all of us, hopefully. Okay? There is a pump here. It pushes the potassium inside the cell where it should be while bringing out sodium. Sodium, potassium, ATPase, you know it very well. It is in every single cell, right? Think about it. The concentration here is 140 to 160 millimole per liter. Wow, look at this. 4 versus 150. 5 versus 150. This sodium potassium ATPase is born with you day one, minute one. It will die with us at the age of 120. No stop whatsoever, no break whatsoever. The whole time, think about this. What kind of a pump do you know in your life that constantly for 90 years, for 100 years, nonstop works and works in a way that the concentration here is 30 times more than the other side? See how strong, how potent this pump should be the whole life. Major, major deal, right? And then this is how potassium goes in. How does it go out? Through the channels. So what do I say here? Number one, potassium is the major intracellular ion. I think by now we all agree on that. Would you agree? Perfect. Number two, potassium is taken up by all cells through the what I told you, sodium, potassium, 8. This is a big deal. Think about it. Non-stop. 100 years, the concentration is not a little bit higher on this side. Two times, two and a half, 30 times. Just think about it. Are you thinking about it? Very good. Okay. Third is that potassium is one of the most permeable, so it goes out through the K channels. Are we good so far? So now we know how potassium goes in, how potassium goes out. Potassium going in being a big deal, very, very active, and it needs energy. It needs ATP. Okay, so what's the goal of potassium homeostasis? What do I mean? I am a fan of layman language. I don't use homeostasis and all. The point is, how do I manage my potassium? That's the basic thing. Homeostasis of potassium, something, something. The goal is to keep our extracellular fluid, which is our serum potassium, in a very narrow range between 4 and 5. Why do I say in a narrow range? Because this is against our craziness. It means that one day I wake up, I am in a good mood, I eat 2 bowls of fruits filled with potassium. Good for me. Another day, I am not in a good mood, I stop eating. The whole day, I don't eat anything. Or, as a matter of fact, these days is Ramadan. Many people for 15 hours, 13 hours, they don't eat anything, no potassium whatsoever. On one side, you get 2 bowls of potassium filled with um, uh, 2 bowls of fruit filled with potassium. On the other side, you don't get any potassium. Yet, your serum potassium should be between 4 and 5. What's the job of the kidney? Despite what we do, to keep it between 4 and 5. That's the homeostasis. Does that make sense? So now we should learn, how does it manage? When I am on low potassium, how does it bring it out to keep it around 4 to 5? And when I am super high, how does it get rid of it so I stay between 4 and 5? That's the basics of homeostasis of potassium. Does that make sense? Does it? Perfect. I will tell my wife. She says I never make sense. Usual potassium intake is how much? You and I, or we call it American diet. I assume you are on the island, or you're still on American diet or so, hopefully on a better diet. But most of us are around 100. This is another number you need to remember. There's nothing to learn about it. You remember that most of us, the potassium intake is around 100 millimoles per day. How many milligrams would that be? 100 millimoles per day. Do you remember that equation? 1 millimole equals how many milligrams? 39. Let's make it easy for all of us. 40. From now on, we say 1 millimole of potassium is 40, right? So 100 millimole would be how many milligrams? 4,000 milligrams and 4 grams, right? Keep that in mind. If you want to make it easy for you, for sodium is also 100. You remember sodium, we want to be on low sodium, healthy diet, right? It is 100 millimoles per day, the DASH diet. But in that case, 1 millimole of sodium is how many milligrams? 23, 24, right? That's why 100 millimoles would be 2.4 grams instead of 4 grams. If you don't understand it, one of my things about teaching is planned repetition. I will repeat it so much that you will be sick of it. Just give yourself some time. Okay, this is what I told you. Everything that is healthy has a lot of potassium in it. Let's say avocado has a lot of 33 millimole of potassium. Avocado is filled with potassium. Actually, you know what? Here is the deal. We call them healthy because they have a lot of potassium in them. That's the whole point of them. Potassium is super healthy. They are healthy because of their potassium. Avocado, I don't say hamburger is healthy, but hamburger has potassium in it too, right? Everything has it. Milk has it. Something you see here, banana, 12 millimole of potassium in it in every banana. Obviously, if it is bigger, it goes to 15, 20. If it is smaller, less, right? Keep that in mind. Do I know all of these numbers? Should you know it? You shouldn't know it. I don't know it myself. We just, when we need it, we go Google it and we find it. Okay. Healthy foods, a lot of potassium. Okay. Should we go to another case? Let's learn by case. It's easier. A 24-year-old smart ACSOM medical student returns home to Florence, South Carolina to visit his mom for the spring break. Spring break, you know the deal. The moms fill you up. For breakfast, she serves orange juice, of which he drinks 3 large glasses. Bless his heart. And a bowl of fruit comprised of 2 bananas, 1 grapefruit, 1/3 of pineapple, 2 kiwis. He weighs 70 kilograms. Okay. So basically, what I'm telling you is that a guy goes to see his mom and he gets a lot of potassium for breakfast. That's all I'm saying, right? Not a big deal so far. What would happen to the serum potassium level if all the ingested potassium remained in the extracellular space, meaning we didn't have handling? Basically, I'm telling you, you know what? Let's for 1 second imagine somebody doesn't have potassium handling. Whatever he or she eats will stay where it is absorbed. There is no handling. They are not bringing in, taking it out. Just for a second, we want to know how handling is important for us. Okay, this is all he got, for example. Think about it. Let's go one by one. How much potassium was ingested during that healthy breakfast? This is an imaginary number. So I just came up with this, right? This is not a real number. 52, I said. Okay. So let's say during that episode, he got 52 millimole or 52 of potassium. How much do we get a day normally in normal health diet, American diet? 100. Perfect, right? Just let's say half of his potassium intake is taken in the first meal of the day. Okay. How much is the extracellular potassium now? Do you remember we said 80 millimole is outside, 3900 is inside? Do you remember? So that 80 that was outside, 52 is added to it. So he has now 132 millimole of potassium in the extracellular. Remember, when we absorb, everything goes to extracellular fluid, then it needs to go inside the cells. For him, we said there is no handling. It stays where it was absorbed, right? Do you remember? Do you? You just say to get rid of me. Is it a not this way or this way? This way. Very good. Very good. Okay. How much is the extracellular water? You remember the rule of 60-40-20, right? So 60% of our body weight is total body water. 40% of body weight, or two-thirds of that, would be intracellular water, and 20% of body weight is extracellular water. You remember that 60-40-20. We need to remember this. We need to know this for the rest of our lives. We use it in different clinical settings. Okay, 60-40-20 rule. Okay, so now we should know how much extracellular water he has. I said he was 70 kilograms. So 70 times 20% would be 14 liters. Extracellular water or serum potassium would be that 132 that he got divided by his extracellular water. Easy. So think about it. If he didn't have any handling of potassium with just one meal, he would have died. He would have died at the breakfast table. The potassium goes from 4 to 5 to 9.4. It is not compatible with life. Does that make sense to you guys? That's why handling of potassium is important. We get as much potassium as we want, our body will handle it. Our body will keep my serum potassium between 4 and 5, no matter what craziness I do. Does that make sense? In a way, homeostasis is made to counter our craziness. That's how I look at it. Okay. So now that I told you how important it is, my job is to tell you, so how is it done? What are the components of handling? You told us. I agree. It is important. Now tell me how it is done. That's the next step. So when we take potassium, it comes to our extracellular fluid, like anything else. Everything that is absorbed comes to extracellular fluid. Okay. From there on, there are two mechanisms to handle the potassium. One is immediate, one is delayed. The one that is immediate is this one. Redistribution goes from extracellular fluid into the intracellular fluid. We call it redistribution. It hasn't gone out of our body, it is just pushed into another compartment inside the cells. Would you agree with me? The second part would be excretion, meaning that a little bit delayed. This one needs a little bit time, a few hours. This one, then either through the colon or the GI tract, we get rid of it. And we're going to talk about these two mechanisms in a second now. So we have two mechanisms to get rid of potassium that came to the extracellular fluid. One would be redistribution, pushing it into the cells. The other one, a little bit more delayed, to get it out of the system. Okay. The first one would be redistribution. And what is the most important um, hormone involved in redistribution of potassium? Insulin is here. Thank you. When you have a lot of insulin, it pushes potassium inside the cell. When I have hypoinsulinemia, when I have low insulin, the reverse happens. The potassium goes out of from inside the cell outside of the cell. Does that make sense? Does that make sense? So if I am diabetic, if I have low insulin in my body, do you think I am prone to hypokalemia or hyperkalemia? What do you think? Why are you so good? Yes, you're right. You're right. I am prone to hyperkalemia because there is not a lot of insulin to push my potassium inside the cell. They stay outside. Hyperkalemia. And you are going to see it in your practice over and over again. People who have diabetes have a tendency for hyperkalemia. He takes one banana. I take one banana. His potassium is higher than mine. because my insulin pushes it into the cells. For him, there is not enough insulin. Does that make sense? Perfect. So when you tell me that it is in the intracellular fluid, the redistribution pushes it into the cells, are all the cells getting the same amount of potassium? No. There is a storage unit for potassium in the body. And what's that storage unit? You already saw those tennis players. Where do they store their potassium? Muscle, 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 right? So muscle is number one. And I wouldn't do justice if I tell you three places: muscle, bone, and liver. They are. But think about the proportion. This is muscle, that's the rest. Muscle is the main one, followed by bone and by the liver. Does that make sense? Does it? Muscle. So now I have another question for you. They call you for you are, let's say you are part of Médecins Sans Frontières, the Physicians Without Borders, right? They call you. There is an earthquake in Turkey. You go there. There is earthquake. Many people are under the buildings, so their muscles have been crushed. When you do labs, do you think you will see a lot of hypokalemia or hyperkalemia when the muscles are crushed? Hypo, hyper? Yeah, because they are coming out of where they were stored, right? Exactly, that is true. The main reason why people die from nephrologic standpoint in earthquakes, hyperkalemia comes out, the muscle stops, the heart muscle stops working. Does that make sense? He's not dying from the bleeding. He dies from his potassium, his own potassium. Does that make sense? The same amount of potassium in his body, just from the compartment it should be intracellular fluid. Now it's shifting to extracellular fluid because the muscles are damaged. Does that make sense? Does it? Are you saying it to get rid of me? Very good, very good. Excellent. So now that we are talking about redistribution from extracellular to intracellular fluid, there are a number of mechanisms that pushes the potassium inside the cell, meaning that this sodium potassium ATPase will be working like crazy because its speed, its rate changes. If it goes very fast, there will be a lot of potassium going inside the cell. You will get hypokalemia. Serum potassium will go low because the potassium is pushed into the cell. Okay. So what are five of them I put here? Three of them I said is more important for your tests. But all five we need to learn. The first three are really important for actually the clinical scenarios. Alkalosis, high insulin. Now we knew it already, right? Insulin, we said high insulin pushes the potassium inside the cell. Beta 2 agonists, the one that we use for asthma, they push the potassium inside the cell. So if I treat a patient with asthma in the ER today, I give them some beta 2 agonist. Do you think he will be prone to hyperkalemia or hypokalemia? Hypo, right? Because it pushes the potassium inside the cell like insulin. Very good, very good. The other two that you and I we need to remember, barium poisoning. Barium is the one that they give to do GI imaging. Much less commonly used these days, but barium poisoning when they were using it. And thyroid hormone. Think about it, it's like insulin. If my thyroid is working too fast or too hard, it pushes the potassium inside the cell. Isn't that crazy? Okay, we know about the redistribution this way. What about the other way? What are the ones that make this pump work less efficiently? Not a lot of potassium goes in. So basically, potassium goes out of the cell because the exit channel is always there is leaking into outside. Unless this one works fast, there will be more potassium outside of the cell. So what are the reasons for hyperkalemia? The opposite of what I just told you. It's as easy. I told you alkalosis pushes it inside the cell. So acidosis brings it out. Glucose going up, insulin going down, and cell injury, I told you. digoxin is used less often, and beta blockers, we use them. They make you, I was prone to hyperkalemia. They probably don't give hyperkalemia per se, but if I have that and I get a lot of potassium, I have a tendency my serum potassium to be on the high side. Okay, so this part, I think we took care of it really nice. This part we took care of it. Redistribution. We talked about insulin. We talked about what the what are the other mechanisms by which the potassium is pushed inside the cell or pulled outside. Now it's time to talk about the second part of it, the one that we said is a little bit more delayed. You see the difference between arrows, kidney, and the colon, right? It's favoritism. A nephrologist talks always about the kidney, doesn't think that colon is important, right? No, the reality is that when excretion happens in the for the potassium, 90% is the kidney. Colon or GI tract has a very minimal impact on the potassium excretion. And I'll tell you in a minute what is that impact. What is the main hormone here? For the redistribution, we said insulin was important. For the excretion, when we want to get rid of potassium out of our body, which hormone is important? Aldosterone, which is written here. We are going to talk. Aldosterone is one of the obsessions of nephrologists. So during this week that I am here, you are going to hear a lot about aldosterone from me. Just to make it easy for us from now on to get this out of our way, colon 10% of the excretion. It's not a big deal. It's only a big deal in one pathologic situation. At the beginning of the day, we don't want to be gross. Let's say somebody, most people have one or two bowel movements a day, one bowel movements every 2 days, things like that, right? If I am on chemotherapy and I have major medicines that give me a lot of problem with my GI tract, do you think I may have 25 bowel movements a day? Yes, that's unfortunate, but they I hope nobody goes through chemotherapy, but once they go, some of the side effects are worse than the disease itself. And this is one of them. Sometimes they have 20, more than 20 bowel movements a day. That's when hypokalemia can happen because of potassium going out. In really extreme situations, not one or two, three bowel movements a day. Does that make sense? Keep that in mind. That's why this 10% is there, but in normal physiologic circumstances, it doesn't play a major role. It only plays a role when it goes higher than usual. Does that make sense, guys? Perfect. Okay, now I just put it here. So do you think this is a colonic cell? This is a cell in the colon. Do you need to learn all these transporters? No. Do I know them? No. I just put them to impress you, right? All I wanted to tell you is that there are lots of transporters in the colon cells, and some of them are dealing with potassium. So when we have major activity in the colon cells, we might lose potassium in a significant way. Does that make sense? That's all you need to know about this side of the camp. But the rest is the beautiful kidney. Let's talk about the kidney. Do you remember the parts of the nephron? We have 10 different parts. It starts from the glomerulus here, the proximal tubule, the loop of Henle, the distal tubule, collecting ducts, and then out. Okay? So there are 10 different ones. Yeah, you know it one by one. So kidneys are the primary regulator of potassium balance. These are the ones we said 90% of the excretion of potassium will happen here. Redistribution did not get rid of the potassium out of the body. It just pushed it temporarily into the cell. Now I have to get rid of the potassium. Does that make sense? It cannot stay in the cell forever. It will leak out. So it pushes it inside the cell while waiting for the kidneys to get rid of it. Does that make sense? You see, this homeostasis is so beautifully orchestrated. When you think about it, all these are one after the other planned for all of us. every single moment of our life, not once in a while. Every single moment of our life, they are at work. Okay. The three sites that you need to remember for potassium handling among those 10 sites are these three. Proximal tubule is an important one, probably the most important part. Thick ascending limb of loop of Henle and collecting duct. These are the three parts that play a major role in handling of potassium through the kidney. Let's start with the proximal tubule. Why did I say it's the most important part, probably, in terms of quantity at least? Because 65% of the potassium that is supposed to be excreted, it will be through the proximal tubule. And there are two different mechanisms by proximal tubule to get rid of this potassium. The first one is the early proximal tubule, right after the glomerulus, when you have filtered the blood. Early urine is coming out. The potassium is reabsorbed by water through solvent drag. So your solvent drag, what it is? Think about it as flood. When there is a flood, there is chair in it, there is a car in it, there is a table in it, there is a TV in it. If they are super heavy, they are less likely to move. If they are super light, they go fast. Does that make sense? This is solvent drag. Proximal tubule, if you think about it for everything, not just for potassium, proximal tubule is the worker of the kidney. The rest of the kidney is kind of lazy. This part is not. This part is not super smart, but it's very hardworking. Have you seen there are two different type of people? Super smart and hardworking, it's you. But there are other groups that are hardworking but not super smart, right? And there are some people that are smart but not very hardworking. Proximal tubule is not super smart. There is not a lot of regulated hormone thing. It just absorbs everything. But it is very hardworking. Like here, 65% of the potassium is absorbed by the and amino acids, glucose, sodium, everything is absorbed by proximal tubule. Proximal tubule, not so smart, but hardworking. Keep that in mind. Okay. So the first part is solvent drag. As it absorbs the sodium, the water always follows the sodium. The water is going in. Potassium is a small molecule. It's just dragged into the cell. Solvent drag. Does that make sense? Easy passive absorption. Okay. Late proximal tubule is a little bit different. Late proximal tubule, it tells you that sodium is absorbed, potassium is absorbed, then there is chloride that goes up. When chloride goes up, it is going through the paracellular between the two cells. The chloride goes. When the chloride goes, the potassium will follow because when chloride goes in, it is negative. There's a lot of charges, positive charges on the luminal side. So some of the ions that are positive will push themselves into the paracellular space. So basically, the first part of proximal tubule, solvent drag, it's absorbed through the luminal side, from the luminal side, because the water is going, if I can find, yeah, because the water is going in, the potassium will go in. And the second part would be paracellular. These are the two sites where in proximal tubule, potassium is reabsorbed. And how much of potassium is reabsorbed? How much of potassium that was filtered is reabsorbed? 65% of it. Two-thirds of it is going in already. The second part of the nephron that we said is important in knowing the potassium is the 25%. So between the proximal tubule and TAL, 90% of the potassium is absorbed in the proximal parts of the nephron, right? In the TAL, this is an active transporter. You have heard about it so much, and you are going to hear about it a lot. Sodium, potassium, 2-chloride. The three of them are pushed into the cell. This is an active transporter, right? Sodium, potassium, 2-chloride. So this is where the potassium is absorbed when it gets to TAL. And as you know, loop diuretics are the ones that are blocking this. So if I use loop diuretics, what are the three ions that I'm going to excrete or to lose? Sodium, potassium, 2 chloride. You will see patients with heart failure that take a lot of loop diuretics. These are the three that are low in the cell. Okay? Loop diuretics like this, which will be one of the transporters in the TAL that helps with absorption of the potassium. The second part is again paracellular. So paracellular is working both in the proximal tubule and also in the loop of Henle for potassium at a lower extent, obviously, right? And then from this side, there is K channel where the potassium can go inside the cells after that, goes outside of the cell, goes to the blood side. Basolateral, this is the luminal side, if you can see it. I myself have a hard time seeing it, and this is the basolateral. Okay, so we learned about where in proximal tubule, where in TAL. What am I owing you? What is the third one that I told you is important? Collecting duct. Perfect. Now it's time to talk about that. Yes. And remember, late distal tubule and collecting duct, it's just a progressive change. It's not like a road that you stay here, I am distal, from here, I am collecting duct. No, there is a just progressive change in the cells that it goes from the late distal tubule, goes to the collecting duct. So here, the difference is so far, everything was passive. Now it is regulated, meaning that there are transporters. Well, yeah, transporters were also sodium potassium 2 chloride was a transporter. What's the difference? What's the deal? The deal is that here there are hormones that make it work harder or less. So it is regulated with those hormones going up and down. The absorption secretion will vary. It was not the case in proximal tubule. It was not the case in TAL. Am I clear? Am I? I don't see a lot of knots. Let me go back and say. So there are three parts in the kidney that are involved in excretion of potassium. Proximal tubule, loop of Henle, collected duct. The first two are involved in absorption, but they are not regulated. The more we have, the more is absorbed. Third one is regulated. There are transporters, but they are regulated by hormones. So if that hormone is high, I will have more absorption or secretion of potassium. Does that make sense? Perfect. Okay. So the potassium secretion generally parallels in. So let's go about the distal tubular collecting duct. We have some cells that are called principal cells. You have heard the name probably. So this is a principal cell, for example. So what happens is that they have some epithelial sodium channel, ENaC. You know about it probably by now. Epithelial sodium channel, it's called ENaC, right? So what it does is that it takes, let me come here. Being short doesn't help, but you are going to hear. Sodium goes in, potassium goes out. This is super important. You are going to see solve a lot of clinical scenarios by this mechanism. So sodium comes in, potassium goes out, and this is regulated by aldosterone. The more aldosterone I have, more sodium comes in, more potassium goes out. Remember, I went through two parts of the nephron. I never talked about excretion. It was all about absorption. This is the first time you are hearing from me excretion of potassium outside of the cell. This is super, super important. Potassium goes out. This is how we excrete our potassium. Probably the most important mechanism, actually. Okay? Aldosterone has that. So, what is very important is that, so this is epithelial sodium channels, we call them ENaC. Okay? So, think about it. I have a lot of potassium in my body. I come to the ED with hyperkalemia, right? The ED physician wants to get rid of my potassium. Is it a good idea to give me something that has a lot of sodium in it? What does it have to do with potassium? Get rid of my potassium. You're giving me sodium? Are you crazy? Why do they give me a lot of sodium? They think about this mechanism. They say, hey, if I give this guy a lot of sodium, the sodium goes inside the vein, gets filtered in the kidney, goes into the tubules, comes to this distal tubule here. The more sodium he has here, the more potassium he will get rid of. Does that make sense? That's why those who increase their sodium intake, they will get rid of their potassium through this. If you haven't understood this, you need to think about it a little more tonight and come to me tomorrow. Use sodium containing IV fluid to treat hyperkalemia because it increases distal sodium delivery, which will get rid of potassium. This is super, super important. Are we good? Perfect. And if you haven't understood it, remember what I told you. My philosophy of teaching is planned repetition. You are going to hear this from me a few times this week. Okay. The second type of the cells that are in the distal tubule collecting duct, they are called intercalated cells. And you know, they have alpha and beta things, but that's not the issue. The issue is that this one is also reabsorbing potassium, just like the other parts of the nephron. The difference is that they are also affected by aldosterone. By this, potassium goes in, H comes out. HK ATPase. You had sodium, potassium ATPase. Now you have hydrogen potassium ATPase here. So again, it works through. So this one again is absorbing potassium. So if I tell you in the whole nephron, where is the regulated absorption of potassium? What do you tell me? It's regulated. Absorption is everywhere. There's three parts, but there's one of them that is regulated. Which one is it? It's here. Does that make sense? It is What does it mean regulated? Meaning that if I have a lot of aldosterone, it works harder. Are we good? Perfect. So renin angiotensin aldosterone system. Well, I am big on giving you 10 minutes because we started a few minutes late. I go the 50 minutes, I give you 10 minutes off, and then we come back. Renin-angiotensin aldosterone system, you know about it, you have heard it so far, and you are hearing about it from me and others in the kidney. Angiotensinogen is made in the liver. Then we have juxtaglomerular apparatus in the kidney, including macula densa. If you remember, it makes renin, and renin changes angiotensinogen to angiotensin 1. Then there is an enzyme which is called ACE, angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. Then angiotensin 2 goes to the adrenal gland and makes us secrete aldosterone. Aldosterone goes to the principal cells. And what does it do? Increases the number of open sodium channels, also affects the potassium, the hydrogen potassium ATPase. It works on both of them, but like many other biologic systems, one of them is dominant. Which one is dominant between the two of them? Because one of them is absorbing the potassium, one of them is secreting the potassium. Which one is the dominant one? The secretion part. Keep that in mind. Aldosterone has two different effects in principal cells. One of them is absorption, one of them is secretion of potassium, but secretion is the most important one. So the net effect would be potassium secretion goes up. Okay? Well, you have a tendency for hypokalemia. To summarize everything that I told you today, I told you renal tubular potassium handling has an unregulated component which is happening in 65% in proximal tubule, 25% in the loop of Henle. So 90% is not regulated, right? Okay. This 10% that is regulated by aldosterone and then potassium secretion in principal cells, potassium absorption in intercalated cells. In exchange for what? Potassium absorption in exchange for what? Hydrogen. Very, very, very good. That's why we might get alkalosis. The hydrogen is pushed out. If I have a lot of aldosterone, I am prone to alkalosis. My hydrogen is out. So just to tell you that how progressive we are, our collecting dog has its own Twitter account. God bless your heart. All the nephrologists are progressive. Okay, summary. The great majority of potassium is inside cells, mostly in the muscles. Remember Djokovic, number one tennis player. You remember him eating his banana? You remember the rest. Potassium homeostasis includes internal one, which is redistribution, pushes inside the cell or comes out of the cell. External one is GI or kidney. Which one is important, GI or kidney? Very, very good. Kidney is always one. Redistribution can have major effects on serum levels. We talked about it. Renal excretion involves potassium secretion, occurs mainly where? I told you everything was about absorption except for one place. Principal cells of distal tubules and collecting. Do you remember that? We are going to remember it for the rest of our lives. Aldosterone is the primary hormone involved in potassium regulation for the secretion part. For the redistribution part, which hormone is important? Which one? Insulin. Perfect. Thank you very much. And I will give you, what time is it? Let's give you the full 10 minutes. 8:55. At 9:05 we start. Thank you very much. Thank you.